Hi everyone, we are here at Community Live by Hyland. I'm super excited to be with Shankar Sridharan from NHS.
Yes. Hi.
Shankar, welcome to the Ravit Show. It's your debut. I saw your panel discussion yesterday. Super fan and love all the insights that you shared. But super excited to chat with you on the Ravit Show today.
I think I'm more excited to chat with you. I think your reach is amazing, and so thank you so much.
Appreciate it. Shankar, quick question for you. You've been doing amazing things at NHS, but just for audience, would you like to quickly introduce yourself? Tell us more about what do you do?
So I'm Dr. Shankar Sridharan. I'm a baby heart doctor. You might think, why is there a baby heart doctor speaking to you about AI?
Exactly.
So I'm also the Chief Clinical Information Officer at Great Ormond Street Hospital. Great Ormond Street is the oldest English-speaking children's hospital in the Western world. More recently, I've become the National Clinical Lead for Artificial Intelligence for NHS England.
Nice.
So for the NHS. And so my role is to essentially bring AI to the front lines of healthcare. You might ask, why me? I think it was an accident. They probably made the wrong decision. I think in about 3 minutes there'll be a 7-year-old who knows more about AI. I have, together with some really smart colleagues, we've led the largest generative AI program with ambient voice across the globe and the NHS. And you might think, why? And the reason was to scale. So there are lots of hospitals doing little pilots. We wanted to actually take a scientific approach and say, does ambient voice technology and Gen AI work? And so with megalomaniacal tendencies, I persuaded NHS England to do the largest evaluation. So we've done it across care settings. So it's not just about pediatrics, because I'm a baby heart doctor.
Yeah.
We've looked at it across adult care, pediatrics, mental health, primary care, London ambulance, community care. And the results are worryingly good. And so we said we could do 5 care settings over 18 months and see 5,000 patients. We've done 9 care settings and seen 17,000 patients.
Oh, wow. That's massive.
And the data is impressive. And so we've taken a really scientific approach. So a phase 0 study in our innovation lab, a phase 2 study with professional medical actors, like for OSCE exams and real doctors, but in a fake EHR.
Yep.
And then real patients, real doctors, a real EHR, and then scaling across settings.
Yep.
And what do the results show? Well, the results show that there are multipolar benefits. So there's an increase in direct care of 25%. What does that mean? So currently, if you imagine you're waiting to see your doctor, sometimes for months or a long time, and you go into that appointment, and they chat to you, and then they look away and they type on their computer. Why? Because we have to make high quality medical notes. But that really damages cognitive load. I'm now thinking about the documentation, but I should be thinking about what's wrong with you, why are you here, what's next, how can I make your healthcare better?
Yep.
And so this technology supports documentation, but it also supports the clinician.
Yep.
But more than that, increases productivity.
Yep.
So the appointments are shorter. For example, in A&E, documentation time, accident and emergency is reduced by 51%. Actually, often technology is not assessed properly. And so we did an independent economic impact assessment with a really smart group called YHEC, York Health Economics Consortium.
Okay.
And essentially the technology allows every doctor in A&E, accident emergency, to see at least 1 extra patient. So if we scaled this across the UK NHS, we could see 9,279 extra patients every single day.
Every single day.
Every single day. So
Oh, wow.
9,200. I mean, that's colossal.
Yeah.
And in addition to that, that's a capacity benefit of over 650 million,
Yeah.
a documentation benefit above that of 160 million. And so you kind of think this technology has benefits for economic impact for health systems, but it allows doctors to do their job better. What do I mean by that? The reason I do this is that I really believe that digital capability can help us provide smarter, better and kinder care.
Yep.
So I think that's one of the reasons that I'm in this role at the moment.
Yeah. Shankar, thanks for sharing these details in great numbers there, great statistics, 9,200 plus lives that the patients that you can see every day is huge, definitely. It just makes me think, something like this is happening right now, and how did it all start? The question is basically why didn't this happen 3 years back?
Okay, I think that's a really great question, but there are so many reasons to unpack that. I think the technology didn't exist till relatively recently. So look, AI has been around for ages, but the way I describe it is that we had this whole planet called algorithmic AI, initially focused on things like imaging. But
Right.
my hospital isn't having issues because my ophthalmologist can't look at enough retinas.
Yep.
It's more how we deliver healthcare. And so generative AI suddenly is a whole new planet
Yep.
with capabilities that extend our reach. And one of the really novel things about it is its ability to harness unstructured data. And so look, lots of hospitals have really detailed computer systems called EHRs, but an EHR hasn't increased productivity, and many clinicians find it difficult to navigate. Computer-human interaction is a nightmare, but it is safer. You actually get a much better narrative, but they're expensive. So algorithmic AI required huge amounts of digital maturity, which isn't always available to small hospitals or small practices.
Yep.
The whole premise of AI was that it would be a leveler, it would allow equity, it would allow small centres, large centres to actually rise together. And generative AI doesn't need a huge amount of digital infrastructure, but what it does need is operationalization.
Yep.
And what do I mean? What do I mean by that? And so there are three aspects, I think, with technology. There's people, process, technology.
Totally.
And for a long time, we've been stuck on, let's buy this software, and then you think it doesn't work. And it doesn't work because people haven't been trained how to use it.
True.
It's not integrated to workflow, and it's a nightmare.
Yeah.
So my analogy is, I do not know how to fish. So if you gave me a fishing rod, I'd probably stab a fish in shallow water and look like a clown. So we need to teach people how to use this technology safely, and I think we're at a point now where we've realized that in order to unlock these potentials, we need to think differently.
Yep.
So my role, I have many roles, but one of the reasons I think I was brought in was because I'm good at actualization, i.e. getting stuff done. So there's no point talking about how do we get it into the front lines of care in a GP practice or an A&E or a hospital. How do we get clinicians using it and patients benefiting?
One thing that I've been kind of, thinking about since yesterday after the panel discussion that you all had at the keynote, I was kind of wondering, I talk to a lot of enterprise leaders from finance, healthcare, and what I kind of sometimes hear a lot in general as well, the articles that we read, it is always said that, oh, these are regulated industries. These industries will be the last ones to actually get into something like AI implementation. They would want good use cases first, and then only they'll be actually going out and saying that, oh, yes, we will implement AI into our systems. But in your case, it's totally different.
No, I don't think it is actually. I think it's the opposite. So, as I said, I work at Great Ormond Street Hospital. There is something more precious than your data.
Okay.
Do you know what it is? It's your child's health data.
Oh, for sure.
Exactly,
Yeah.
for sure. I mean, without a doubt. And so there's a question of probity. Probity is a really interesting word. It means professional integrity. And so the moment I tell you I'm a baby heart doctor, there's a degree of implicit trust. And
Totally.
yet, we have to make sure that we follow governance and that we follow assurance, and both are slightly different things. Okay.
Yep.
Governance is making sure that we put in systems so that we have data safety, cyber safety, clinical safety.
Yep.
Because that's what you expect. You don't want me to buy something from kind of a Radio Shack or a tiny shop and say put it in and then see risks. So at Great Ormond Street, we were really good at following governance, and so
Nice.
in some ways
Nice.
that slows us down. But you expect nothing less. Would you fly on an airplane without the systems that have been checked? No, you assume.
Not at all. Yeah.
You assume that, and it's not an assumption. You demand that your doctors are trained and that they're going to do safe practice. So that's governance.
Governance.
We now move to assurance, which is partly this is a world that we are slightly untrusting in. And partly it's because of the whole construct of AI. The name itself is not great. Artificial, as in artificial sweetener. And then, society and culture has made us think of the dangers of AI, like the Terminator paradox.
All right.
And all of those things. And so this isn't a reason to say that we want to dehumanize medicine, far from it. But we want to essentially supercharge our staff to extend reach, to deliver greater good on a greater scale. And so I think it's not that healthcare is impervious to this. I just think it needs to be approached in the right way, which means we move at the speed of trust. And so how do you create trust? You create trust by making sure that you've got people that have thought about this, that are thoughtfully putting in these systems at pace. But we have problems.
Yep.
And I think one of the problems, well, we have multiple problems, but one of the key problems is moving forwards. So at the moment, the NHS and many health systems across the world, including the US, are stuck in pilotitis.
Yep.
Every single hospital is piloting AI. I think this is a type of FOMO. So everyone goes, oh yeah, we're really into AI, we're going to do a pilot. The pilot is a tiny group of people, underpowered, it won't show effectiveness, and there's no plan to scale. And so how do we move? So the work that we've done in the Drive unit, so Drive stands at Great Ormond Street, we have an innovation unit called Drive. It stands for Digital Research, Innovation and Virtual Environments. And so I work with some really smart people that have helped me lead this thing together. We've led it as a team across this. And the plan was that we would develop a national pilot. And so what's next? What's next is how to scale, how to operationalize AI. And the reason things fail isn't because someone had a great idea, it's because there's no strategic delivery. Businesses fail for that reason, companies fail, healthcare, IT often struggles.
Yep.
So let's come up with a strategic delivery plan. And I think that's kind of our focus at the moment.
Nice. Yeah.
I think looking back, I mean, when was the last time you used electricity? This morning? When you brushed your teeth, turned your lights on?
Yeah.
Currently, it's like we're piloting electricity. So we have to move forwards, and I think the way to do that is to create trust, making sure that your systems are governed, you've passed governance, they're assured. The cost is an important thing, so your systems understand the cost. And then actually that we have a safety culture to make sure that we're moving forwards. There is another huge problem, and that problem is our imagination. Okay, Einstein, I think, said that intelligence will take you from A to B. Imagination will take you everywhere else.
Totally.
And at the moment, we're like caveman with fire. Oh wow, this fire thing's amazing. I can burn a piece of meat, without any understanding that this is how you split the atom. This is how you use combustion to go to the moon. And our use cases are somewhat mediocre at the moment. Your documentation will definitely help. Look, it's going to be tangibly good.
Yep.
But what's next? What's next is not using. Look, I'll give you an example. So we have these things called MDTs in medicine, where lots of clinicians come to review a case. So at Great Ormond Street, we have lots of safety protocols. So outside of an emergency, even during an emergency, we would take a child's case to a panel called an MDT.
Yep.
Instead of my 24 years experience, there's 10 of us, 10 consultants, junior doctors, nurses, ITU doctors, and we'd discuss the case. It's deliberately done in a very adversarial way in cardiology. One of the juniors presents, or one of the registrars presents, the other consultants comment, and I comment last because I know the family and I'm too emotionally close, probably. And so people are now saying, but preparing the MDT means you have imaging data, X-ray data, the clinical story, the results, and people are going, AI will be great for bringing the documentation. That's small fry. I don't want that. I want the 10th man. What do I mean by that? I want the AI to be another voice, but one with greater vision that can look around corners to say, actually, this operation would benefit from this approach, these are potential complications, have you considered this, or have you not considered doing it? And that is intelligence.
Yeah.
That means that actually, now instead of having 9 humans in the room, I have an AI that's intelligently telling me, not telling me, nudging me, pushing me, making me think.
Yeah.
And that was the whole reason in healthcare we had these things called differential diagnoses. The differential diagnosis wasn't for me. I'm supposed to write one. It's supposed to be for the next person to go, oh my God, Shankar's stupid. It's not epilepsy, it's so-and-so, because that has stimulated thought. And so we come on to AI replacing your brain. No, it's not there to replace me.
Yeah.
I'm the superhero, AI is the cape. I just need a lift. And so...
That's a very good point. Yeah, for sure.
When we talk about workforce, listen, I think at every stage of technology, people have been worried about losing jobs. This happened at the time of the printing press. This has happened with combustion engines, with the creation of... I think people's work will be different, and actually I think there's probably scope for more jobs.
Exactly.
It's just the nature of your work will be different, and so will it allow us to do more work, or better, or more meaningful work, and actually get time back? So, you know, in an accident emergency, what the doctors are reporting, it's a really unusual environment. You have an incessant flow of people. What they're reporting is that they can see more patients, and they feel better at the end of the shift. They can go out with their family or go out for a drink. And so, that's why the benefits are multipolar.
Yeah.
And so I think what's next really is us moving forwards. Not little pilots, but saying, let's do this, but let's make sure that we put in the safeguards so that we create trust and we move at the speed of trust.
Yeah, I love it. Shankar, these are fantastic insights in one question that I had, because we are here at Community Live, and I've seen the partnership that you all have with Hyland as well. How did it all happen? What is the story behind that?
Yeah, so the reason I'm here is that Hyland have been amazing partners
Yep.
to us. And actually, they really support us running our hospital. So we went live with an Epic EHR in 2019. We started that process in 2017. And in 2018, I realized something. There was a problem. About 70% of US sites use this thing called Hyland. And I kind of thought to myself, these are leading hospitals. They would not waste money on something expensive. What have we missed? And then I realized that document management was key, and that actually Hyland strengthened that above your EHR. What do I mean by that? When I go to clinic as a doctor, I want to find my last letter because it's brilliant, okay? I also want to find the last letter that that child or family has seen another clinician.
Yeah, yeah.
I need to find that quickly
Yep.
because I need the information to construct how I'm going to approach this child. Now, lots of document management systems function like a continuous toilet roll of just one PDF in a strip. How can you find anything? So in order to facilitate me being my best, I need information at the point of care.
Nice.
So 95% of my hospital have never heard of Hyland. They press a button in Epic called Media, and the integration is at patient level, encounter level on the app. But they've been brilliant. So they help us run a hospital safely. We've actually co-developed products together. There's a product called Mind Palace that we've been working on, which essentially is a knowledge base of all our tip sheets, guidelines, repositories, so that we can access information. So let's just say we have a patient who's got epilepsy, but they now have a stroke. That stroke, how to manage a stroke, is not in their chart. It's scattered on guidelines, protocols around the hospital.
True.
Imagine being able to harness that on your phone in real time at the speed of light.
Very important. It can save lives.
Absolutely, it can make us do our job better.
Yeah, yeah.
It's an enabler.
Yeah.
So we have a version of Mind Palace which involved Elasticsearch and meta tag search, but now with Gen AI, we can take it to the next level.
Totally.
And so Hyland have been really good partners. I also really believe that they're moving quickly and in the right place. I mean, I think what we're seeing now is beyond the use cases of documentation, but agentic AI, agents that can help with workflow, can help us run a more efficient, better hospital so that we can focus on what's important. What's important? Healthcare.
Healthcare.
So looking after you, your family, your friends, and actually doing a better job. And so I think the reason I'm here is, as I said, Hyland have been brilliant. Really good people. You know, I think
It helps.
well, no, I think it's key actually. I don't think people choose technology and the technology alone. You have to have good technology.
Yeah.
But it's, as I said, people, process, technology.
People.
And so that's why I'm here. I've never been to Community Live, and actually being in Vegas is an interesting experience. Mainly because navigating the jet lag, it's been a challenge. But yeah, I think, listen, my son has just got into medical school, which I'm incredibly proud of. But this is a super exciting time for humanity and for healthcare. We have to do it right, but we have to move forwards. But
Moving forward is like the key, is what I'm kind of hearing, with all the governance, compliance, intelligence, imagination in place, and things can change.
But you have to do those things. And so instead of take those bullets out of the chamber, sort the governance, sort the assurance, set a price,
Yep.
and then now move past AI literacy, which you have to do,
Yep.
and actually start empower a workforce to be guardians of safe AI who will actually find the best use cases.
True.
And we need to aim to do more than just burning a piece of meat. Seriously, it's really exciting. And actually, the pace and speed at which this stuff is changing is also quite important. And so, yeah.
We are definitely in these exciting times, and can't wait to see where and how we'll be moving forwards as well. Like you said, one last question for you, Shankar. How do you see the space? I'm not going to say in the next 5 years. I'm just going to stick to a short-term space, and that too just specifically the healthcare space in the next 6 to 12 months.
So I think the next 6 to 12 months is going to be interesting. I think there are a couple of competing issues. I think governments around the world are thinking of deregulating AI.
Yep.
To improve velocity and uptake. I think healthcare, we need to approach that carefully. And so this isn't about choosing a specific company, but about choosing assured, benefits-proven technology.
Yep.
And so I've helped create a tech evaluation framework called AI called TEST. T.E.S.T, Technology Evaluation Safety Test.
Okay,
It's
nice.
a vendor agnostic framework. There are two sections. Section A is platform assurance, with requirements for governance and safety across cyber, data, and clinical. Weirdly, section B is something interesting. It's a benefits assessment across 12 domains, anchored across clinical effectiveness, does it work, financial impact for the hospital and the health system, and third, workforce. Everyone talks about the workforce, but does it make the workforce better? Does it improve their joy at work? Is it easy to use? And then there are other sections such as carbon footprint, electricity, is it a sovereign AI? Does it integrate with virtual systems? Is there integration? Once you approach a systematic way, but look, it's 2025, and not a single health system I know has a standard way of assessing technology. And so we have to be smart, but
Smart
things
enough.
are starting to fit.
Right.
Okay, we can assess technology, we have a plan, let's just start moving on that plan.
Exactly.
I hope that's been okay.
This is fantastic. I love it. Shankar, you've been amazing in terms of sharing all the details with us about how the healthcare space is moving, use cases, giving us the the point of view where it's also about the imagination. It's not only just about the technology. People, processes, like you said, are very important to make sure that this is successful. We can go into various directions when we kind of think about things negatively as well. But this has been wonderful experience for us as well. I think for the crew here and for the community live as well. We've been hearing great things and great experiences that you have in how it all works behind the scenes as well. So thanks for sharing it. We'll keep the conversation going. I'm pretty sure we'll catch up in London and we'll do another one.
That'd be brilliant. Well, thank
Fantastic.
you so much for the comfort of your time.
Thank you very much,
Thank you.
Shankar. Thank you everyone for watching us.